Hi, everyone. Welcome to day 3 of the AP CCMI conference. I'm Professor Glenda Gray, the chairperson of this virtual lunch symposium session. This year's theme is optimizing COVID-19 vaccination in the Asia Pacific. Before we officially start, here's a disclaimer slide. This meeting is supported by Janssen, a division of Johnson & Johnson Limited. The views expressed in these slides are those of the individual faculty members and do not represent or reflect the views of Janssen, a division of the J&J Limited. The presentations may include discussions on off-label use of drugs in your countries. Please refer to the relevant SMPC of any compounds mentioned on this webcast for full prescribing information. As prescribing information may vary from country to country, please refer to your local prescribing information for complete details. With that, let's kickstart our session proper. The objectives of this session are to discuss the public health benefits of COVID-19 vaccines and present recent advances and experience in South Africa, as well as to gain insights into the public health response, programmatic considerations, and the best practices for the successful rollout of COVID-19 vaccines in differently resourced Asian settings. Here is our agenda to start. I will firstly discuss COVID-19 vaccination and the South African experience. Then we will have a panel discussion on COVID-19 vaccine rollout in differently resourced settings in Asia, particularly in Korea and the Philippines. We will have a short question and answer session before closing. There are 3 of us in this session who will serve as faculty for today. I am Professor Glenda Gray, the CEO and President of the South African Medical Research Council, the SAMRC. Joining me is Professor Anna Ong-Lim, a professor and infectious disease specialist at the University of the Philippines and the Philippine General Hospital. We are also very happy to have Dr. Yong-Jun Choe, an associate professor of pediatrics and pediatric infectious diseases at Korea University College of Medicine and Korea University Annam Hospital. We are very happy to be part of today's session along with my fellow speakers, and we hope you will enjoy today's session. With that, let me kickstart my presentation on the public health benefits of COVID-19 vaccinations. The benefits of COVID-19 vaccinations are important. They're both private benefits or individual benefits, and this is to reduce the risk of dying or being hospitalized. There are also public health benefits, and this is to reduce the burden on the health system of people who are COVID infected. There are economic benefits. By vaccinating people, we can keep people in jobs. And there are also social benefits. We are able to protect others. So those who get vaccinated will protect their households, particularly if you live in an intergenerational household. We also want you to know that the vaccines are safe. They've been given to billions of people at a global level. As you can see from this slide, there is an inequity in access to COVID-19 vaccinations, and low middle income country settings have lagged behind high resource settings. One of the things we need to address as we move forward next year is to make sure that the low middle income country settings do get vaccinated. At this moment in time, around just under 3% of people in low middle income countries have access to vaccinations, as compared to almost 60 and above % in high resource countries. So we would have to work very hard to ensure that that we reduce the inequity and inequality of access to vaccines going forward. I'm going to talk first of all about the efficacy of the A26 SARS-CoV-2 vaccine. And I'm going to talk first of all about the single-dose vaccine before I move on to the 2-dose vaccine program. So the initial study, which was a phase 3 study and a multi-country study, evaluated the single-dose regimen as an emergent response to the pandemic. And this single-dose regimen did show and demonstrate durable protection. In the US, the efficacy was 74% against severe disease and 70% against all symptomatic disease. And this efficacy has persisted for 6 months. There are unique immunoprofiles with antibodies titers that peak later and persist, and we see durable cellular immunity with persistent responses. This slide shows the how vaccine efficacy persists against severe COVID over time, and we have data out to 210 days, and you can see how the vaccine efficacy has maintained over time after giving a single dose, as measured after 28 days after receiving the vaccination. If we look at symptomatic COVID-19 infection, yeah, you can see that the VE does change over time, but is still persistent with good vaccine efficacy after day 28. However, with the advancement of various variants at a global level, we do see a reduction in vaccine effectiveness. When we look at how we translate this efficacy data into real-world effectiveness studies, I'm going to show you data from both South Africa and the United States of America. This is a lovely slide that shows the month-to-month effectiveness, even in the presence of Delta in the US. And yeah, you can see on the left is a slide that shows how vaccine effectiveness was stable over time, even in the presence of a Delta variant. And yeah, on your right, you can see the Kaplan-Meier that shows still the impact of the vaccine in terms of disease as compared to unvaccinated counterparts. So demonstrating that even in the presence of Delta, we did see real-world effectiveness with the single-dose vaccine regimen. Going to South Africa, we were able to deliver almost 500,000 healthcare single-dose A26 vaccines to healthcare workers in South Africa. In this slide, we looked at healthcare workers who were insured with various medical insurers, so we were able to match them quite carefully with unvaccinated counterparts. And we also compared this to healthcare workers that were in a certain province for sensitivity analysis. And this slide demonstrates that vaccine effectiveness was maintained in terms of hospital admissions, in critical or intensive care, and in COVID-related deaths. And we see a vaccine efficacy in terms of death that ranged between 80 to 83%. In terms of hospitalization, we saw a vaccine efficacy that ranged between 63% to 75%. And then in terms of vaccine efficacy, we saw, in terms of hospital admissions, we still saw good persistence of VE in terms of hospital admissions. We are also able to demonstrate the effect of this vaccine on people who have HIV infection. At a global level, around 2,500 people have been enrolled in vaccine trials evaluating the vaccine effectiveness for COVID-19 vaccines. And we have very little real-world data on HIV. In South Africa, a high-burden country of HIV, we were able to enroll about 40,000 healthcare workers who were HIV infected. And here we see that the vaccine effectiveness is maintained for hospital admissions and for admissions that require ICU or critical care. And you can see that we maintain our vaccine effectiveness. There is a reduction in vaccine effectiveness in healthcare workers as compared to in healthcare workers who are HIV infected in terms of COVID-related deaths. And this reduction in VE, although over 50%, does imply that probably people who are immunosuppressed or HIV infected probably require a second dose of this vaccine. But very important also to look at vaccine effectiveness in people who had other comorbidities, and we can see that vaccine effectiveness was maintained in healthcare workers in South Africa, whether you were HIV infected or whether you had other comorbidities. If we look at the efficacy of the 2-dose A26 SARS-CoV-2 vaccine regimen, you will see the data coming out of COV 3009. And this is a 2-dose vaccine regimen. And the boost was given 2 months after the initial prime at baseline. And this was a large study. It enrolled 31,000 individuals. It was a randomized placebo-controlled study. And as I said, conducted in 9 countries on 3 continents. And here we see that a very good follow-up and participation. And I'm going to show you the results in the next slide. So this is the data that we see in the 2-dose study. here we see the vaccine effectiveness in 3001, which was a single dose study. We see the vaccine effectiveness was around 70% for symptomatic COVID-19 infection. And here we see the data after the boost, which was and VE was evaluated at after 71 days, and we see a vaccine effectiveness of 94% against symptomatic disease, showing the utility of an additional dose for the J&J regimen. If you have a look at the global work, yeah, you see in terms of the single dose 3001, after 28 days, the vaccine efficacy was in the mid-50s, and you see in comparison to the booster, you see a vaccine effectiveness of around 75% at a global level, and this represents data against all variants of concern, not just against the original Wuhan strain. So it's very exciting to see high levels of vaccine effectiveness at a global level, despite the various variants of concern. And you can see that in comparison to the Wuhan strain in the US, the VE did drop from 94% to 75%, but still maintained very good efficacy. So when we look at protection against severe outcomes, again, see profound impact of the vaccine against severe COVID disease with a VE of 100% in this study. So in terms of going forward, we do note that that various regulatory authorities, including the FDA, are evaluating the role of boosts. We've seen with this J&J a homologous boost, 2 doses of the A26 is safe and well tolerated, and that the booster given at 2 months provides very good and robust protection. And that if a booster is given much later, it also provides an increase in antibody titer, which will be well correlated with protection. And so we also want to emphasize again is that the booster dose did increase antibodies against all variants tested, including the Delta. So what about boosting the single dose regimen? We know lots of people at a global level, millions of people have got the single dose vaccine, and what should we be doing about boosting these? So this is a very important slide that shows the durability of the humoral immune response over time. And here you can see in people between ages of 18 and 55, the durability of the immune response was maintained even out to 7.5 to 8 months. We did see a reduction in immune response in people over 65 at this time point, but still good and durable immune responses. By boosting these regimens, we were able to increase the antibody responses between 3.5 to 6-fold, and this just shows you both age groups. By boosting this regimen, we were able to boost the immune response, which will probably translate into a maintenance of vaccine effectiveness. So in terms of the risk-benefit of COVID-19 vaccines, we do know that there are some rare serious adverse events that occur after COVID-19 vaccination, and these only occur after millions of people have received vaccination. And so we know for the Janssen vaccine, there's an occurrence, a rare event of thrombosis, the thrombocytopenia. And with the mRNA vaccines, there's the issue of myocarditis. And we've also seen the emergence of a rare event of Guillain-Barré syndrome after the COVID-19 vaccination. In terms of the potential harms reported overall after COVID vaccination, we just look at the Janssen. This is 3 cases per million doses of TTTS syndrome. And in terms of Guillain-Barré, it's 7.8 cases per million doses. In terms of mRNA, we see about 3.5 cases of myocarditis per million doses of vaccination amongst adults. And this slide beautifully summarizes the risk benefits of COVID-19 vaccination by age group and sex, and looks at both Janssen COVID-19 vaccine and the mRNA. And you can see in terms of the Guillain-Barré syndrome and the myocarditis that even in young adults, one would for every 1 million vaccination, it would be a case of GBS or 4 to 5 cases of TTS, but we would at the same time avert many deaths and ICU admissions. And this impact becomes more evident as well as we go to the older age groups who are very susceptible to COVID, and see tremendous reductions in death, ICU and hospitalization, and you can see that there's a clear risk benefit for using vaccinations at all age group, and the risk benefit clearly is in the balance of being vaccinated. So in conclusion, ongoing efficacy and effectiveness data support the use of the Ad26 SARS-CoV-2 vaccine. And we've seen that boosting increases immunogenicity and will probably become part of the vaccine program going forward. And we have data both on the a boosting regimen of 2 months apart, and we have data of a boosting regimen beyond 6 months. And so we believe that the risk-benefit ratio continues to favor vaccination, and that scale-up is critical for global control of COVID-19. There is a rationale for mass vaccination programs. It's our best defense against COVID-19, including the Delta and other variants of concern. It's the safest way to achieve immunity. It can help control the pandemic. COVID-19 vaccination is safe, and it is monitored all over the world. And again, billions of people have received the vaccine safely, again enhancing the important and the public health benefits of the vaccine at a global level. So this concludes my presentation today, and I'm going to hand over to my other faculty members, and I'm going to ask Prof. Choe and Prof. Anna to kindly share with us the information of COVID-19 in their country, and maybe we can start off with Prof. Choe from Korea. Over to you, Prof. Choe.
All right. Thank you for having me here, Professor Gray. My name is Choe from Korea University Annam Hospital in South Korea. I'll be sharing our experience in Korea on COVID-19 vaccine rollout that have been taking place for the last couple of months. So let me take you to the baseline of this country. It is a very small but has a relatively large population, resulting as one of the most crowded countries in the world, which is quite challenging for the infection controls and prevention measures. The country has the mixed economy and industries, from the high-end IT infrastructures that can be easily converted to the contact tracing system, but also has the factories and handicrafts to produce the facial masks and personal protective equipments, which was quite an advantage in the dealing with the new pandemic in the early phase. However, it is also one of the busiest places, with more than 3/4 of its economy dependent on international trade, largely with the Asian countries, resulting 17 million inbound travelers in 2019, with more than 1/3 of the travelers coming from mainland China. So from public health perspective, many things turn around very quickly in Korea. If you see the infant mortality rate decrease, you'll see a steep slope of decline over the past 60 years, with less childbirths, resulting in the fastest transition of the population demographic in the world. The healthcare system is quite mixed with the public and private system, meaning that nearly 100% of the residents are covered by the universal healthcare system. However, most of the providers are the privatized players who are mandated to be enrolled in the national health insurance system. So on top of this, the country had a couple of the exposures or the experience in dealing with the emerging infectious diseases, including the SARS-CoV-1 in 2001, pandemic H1N1, as most of other countries in 2009. As if you remember, we had the largest outbreak of MERS-CoV infection outside of Middle East countries. This country was one of the frontline first countries that was struck by COVID as early in January of 2020. And the strategy was basically dependent on the rigorous testing, contact tracing, and early isolation and quarantine in all suspected cases. And the early result was quite successful, resulting in less cases and less mortality than that was expected with no such policy. But despite that, there were a couple of waves of the community outbreaks, and in between the waves, you will see the baseline of the monitored incidence getting higher than the previous ones, meaning that we needed some sort of population immunity, either from the massive infection pressures or the vaccinating of large population through the vaccine rollout that began in this year, February and June, which I'll share in the next slides. So in the context of the healthcare infrastructure, the public vaccination program is also an example of the private-public partnership, which includes around 1,000 public health centers and more than 20,000 clinics to maximize the access to get the vaccines. And the baseline immunization rate is quite high, with more than 95% of coverage for most of the EPI vaccines, and has the highest influenza vaccine coverage rate in adults aged 65 years and older. There is an electronic immunization registry that enables the data sharing between the governmental bodies. For example, between the Ministry of Health and the Ministry of Education, they can utilize this system to operate the school entrance vaccination checkups. And if a child did not receive the vaccines without a medical excuse, then the data is shared by the Ministry of Gender Equality and the Family Affairs to conduct the investigation if there's any child abuse or neglect. So lastly, this country has a Korean version of the ACIP, or so-called the National Immunization Technical Advisor Group, that helps the public health sector to practice evidence-based policy based on the making on the immunization strategies. For example, KACIP can bring up the potential vaccine candidate to include into NIP. Then the working group conducts a research to assess the evidence and prioritize the vaccine introduction. The KACIP makes a final decision to advise the Ministry of Health whether or not to include the vaccine to the public program. Hence, this is the country's situation in Korea. Perhaps I can now hand over to Professor Anna to elaborate her country's situation in the Philippines.
Thank you, Professor Yongjun, for giving me the opportunity to share what's happening in the Philippines. And thank you to the session organizers for this chance to share what's happening in the Philippines with respect to the COVID-19 vaccine program. So as has been done in the previous presentation, I'd like to share a little bit about what's the situation in the Philippines. And we currently have about 110 million people living in the country, with a huge proportion actually belonging to the pediatric population. We have what you would call a triple burden of disease, including both communicable and non-communicable lifestyle-related illness being part of the burden of disease in our country even before COVID came around. Our life expectancy averaged about 69 years prior to the onset of the COVID pandemic. The country's health situation, or the country's health governance, is really lodged in our Department of Health. But this is not an entirely centralized structure, because we have a structure where a central office creates policies, but the implementation is really focused or lodged with local government units that implement the different mandates coming from the central offices. So as you can imagine, this devolution can really be quite challenging in terms of implementing programs that have been framed in a central office, perhaps without actually appreciating what's happening on the ground and the resources and the situation that's happening right in the communities. We have recorded almost 2.7 million cases of COVID since the registry was started in January of 2020. And we are currently in the midst of a surge that has primarily been driven by the detection of Delta variants all throughout the country. The data being shown in this slide shows a slight downturn, which since that time has already accelerated. We have actually decreased our active cases from about 82,000 to roughly 60,000 plus currently, which is quite encouraging, and was primarily the result of community quarantine being imposed in many parts of the country, together with an increase in the number of vaccinated individuals. You will see that based on our breakdown of cases, the majority still belong to the asymptomatic and mild groups, roughly about 87% belonging to this category, with the remaining 13 or so percent classified as moderate, severe, and critical. Now, these, of course, are the individuals who need facility-based care, and because the resources in the country are quite limited, where you will see that we only have about 4,000 or so ICU beds. This has really resulted in an overflow of individuals or patients seeking care in our facilities, which was the picture being seen in the current surge. The pediatric population composes a small proportion of individuals affected by COVID, as is true with the rest of the world. So you will see here that we have about 12% of our cases being attributed to children 0 to 19 years old, and the deaths have been quite low, about 1.4% belonging to the age group in pediatrics. The positivity rate for the country has increased recently, again as a result of the surge and also because of challenges in terms of availability of testing resources. But again, this has started to go down, and we're hoping once again to achieve the target of 5% that's mandated by the World Health Organization. So let me hand the time back to Professor Gray for the next topic of discussion.
Thank you very much, Prof. Young-Jun and Prof. Anna, for giving us an overview of your country's situation, both in Korea and the Philippines. I'm going to ask you some questions about your epidemic. Can you give us some insights into your country's response to the pandemic, your vaccination experience, for instance, and the role of various populations and vaccination programs? So let's start with you, Prof. Young-Jun. Let me hear about Korea and some of your responses there.
Thank you, Professor Gray. So in one picture, we could draw this wheel of the vaccination program in Korea. This starts with the technical review, the feasibility assessment, and the assessing the knowledge and the acceptance of the public, meaning that COVID vaccine has to be first get reviewed based on the clinical and epidemiologic data, and to be checked if there's any political willingness and the public health priority in terms of the vaccine rollouts, and if the general publics are accepting vaccine, the full understanding of its pros and cons, and the safety management system and the risk communication system are in place, maybe we could run the vaccination program in this country. So in the beginning, none of the available COVID vaccines were developed in Korea. And if you remember the first half of this year, the procurement was quite challenging. And some domestic facilities have had the contract manufacturing licensure to produce the COVID vaccines, but those were not for the national distribution of the vaccine. So given the constraints in the vaccine procurement, it was decided to obtain the vaccines through the multiple channels, including the COVAX facilities and one-on-one contract with the pharmaceutical companies. And the procurement was quite centralized by the government. Including more than 10,000 consigned medical institutions designated for the viral vector vaccines, and around 250 vaccination centers that were designated for the mRNA vaccines, simply because of the issues in regard to the availability of the freezers and the ultra low temperature freezers. So in terms of the government, each ministerial bodies of the government took their roles in the vaccine rollout. First, the overall management was governed by the Korea Disease Control and Prevention Agency, which is under the Ministry of Health, that runs the public health program in the country. The procurement negotiation and the contract was made by the Ministry of Trade. The rapid licensure process was made by the Ministry of Food and Drug Safety. The air transport was supported by the Ministry of Land and Infrastructure and Transport, and the transport within the domestic land was made by and supported by the Ministry of the National Defense. The local government was in charge of the vaccination practice in each cities and the provinces. The security of the vaccine storage was guarded by the National Police Agency. And the ambulance service, in case of the acute reaction, were supported by the National Fire Agency. And this process was quite possible and doable because the Korean law mandated, in case of the public health emergency, it is the Prime Minister that comes in charge of all response measures. So initially, the vaccination plan was to provide the free vaccination to all population, regardless of their citizenship. And the first priority were given to the vulnerable population in the long-term care facilities and the first-hand responders. Then the senior citizens aged 65 and older, and the persons with disabilities and those with the chronic disease and so forth, such as the essential service providers. And finally, to the general public who were eligible for the vaccination. So this was the original plan. There were slight changes afterwards. For example, last month it was decided to recommend the vaccination to all pregnant women and the children aged 12 to 17. So we began to vaccinate the children starting this week. The 2 mRNA vaccines and 2 adenoviral vector vaccines were introduced in Korea. The new protein subunit vaccine seemed quite promising, but has not been licensed yet. The vaccine schedules and the prioritization follows the tables below. The priority target started from the healthcare workers, those who were living in the nursing homes. Then the target was expanded to teachers, the physicians, essential service workers, then to the general public, from the elderly age group 65 to 74, then to 60 to 64. And in July, because the college entrance exam is quite big deal in this country, the vaccination was provided to the 12th grade students. And by the August, all adults aged 18 and above were eligible for the vaccination. Beginning this week in October, we have started vaccinating children aged 16 and 17 and are expected to expand to age 12 years and older starting the first week of November. So in the context of the easy access to vaccination, the vaccine coverage went up very rapidly. If you see the picture, the shaded graph is the vaccination coverage rate. The line graph is the incidence rate of the COVID. If you see the slope in those who are 60 years and above, you'll see a steep increase between the May and June. And for those under 60 years, also had a quite a increasing the coverage over the past 3 or 4 months. So following the first few months of vaccine rollout, we have begun to assess the real-world data on the vaccine effectiveness in the population level. This is the table of the vaccine effectiveness by the age group for all vaccines that were used in Korea between May through July. The case definition for the outcome would be the severe cases requiring either oxygen, mechanical ventilation, ICU admission, or application of the ECMO. In the left column is the cases, and it's the number of the cases and the rate in unvaccinated people. And the right column would be the cases in fully vaccinated people. And the age-adjusted proportion of the severe cases among all infected cases would be 3.07% for the unvaccinated persons. The proportion would be 0.85% for the vaccinated persons. And for the proportion of the death cases, adjusted infection fatality rate, or IFR, in the unvaccinated person would be 0.39%, while the IFR in the vaccinated person would be 0.02%, which was quite reassuring in keeping up with this vaccination program. As I said, this would be quite unique here in Korea that we have this National College Entrance Examination, which is a quite big deal nationally. So it was decided that the 12th grade students should be prioritized to get the vaccines by the end of August. And if you see the coverage rate, it got really high fast within 4 to 5 weeks, up to 96 to 97%. And if we compare the number of the cases or the incidence rate between the 12th graders versus 10th and the 11th graders, this is quite straightforward. You can see the difference in the incidence rates between these two groups. And as in most places in the world, the safety of the vaccine is quite a big concern in this country, especially when the disease severity is disproportionately better in younger population, where the most of the virus circulation is happening. We have had a published passive AEFI surveillance data in August, showing the reported number of the safety reports of the AstraZeneca vaccine and the Pfizer vaccine that were used between February and April. And this graph shows the reporting rate difference between the two vaccines are not that different. And by the late April, the rate for the AstraZeneca vaccine was 0.7%, and the Pfizer vaccine was around 0.9%. And for the details of the real-world safety data was provided for the informed decision-making the vaccine policy. The most frequent report from the AstraZeneca vaccines were myalgia, fever, and headache, while for the Pfizer vaccine were the myalgia, dizziness, and headaches, and the reporting rate was quite higher for the younger population. So at a baseline, we can all get the allergies and anaphylaxis in all cases who are vaccinated. So in total, there have been 173 cases reported as suspected anaphylaxis. And based on the case assortment using the Brighton collaboration case definition, the rate seemed to be very low, around 1 every million doses of the vaccination, which is quite similar to what the other parts of the world has reported. Given the limitation of the passive surveillance, there were also active surveillance, meaning the surveyors or the researchers reached out to the vaccinated people and asked if they have had any symptoms. This is the data for those who have received the Janssen vaccine, showing that about 80% got symptoms after they have received the vaccine. But this should be taken into account that this vaccine was offered to young adults, first to the military personnel, then to the adults aged 30 to 40. So the population was quite different. And then in the alarming signal for the thrombotic thrombocytopenia following the AstraZeneca vaccination back in May, the benefit cost analysis was conducted to measure the baseline incidence of the thrombotic event in each age groups. The weight between the risk that was estimated in the respective age group and was conducted. The age limit was lifted towards age 40 years and above first. And given this finding, it was lowered down to 30s and above. Hence, so this was the program that was conducted in South Korea over the past few months. Let me hand over to Professor Anna. What would be the pandemic responses in Philippines?
Thank you, Professor Yongjun, for that overview of the Korean experience. I'd like to start off with our country's vaccination experience by trying to expand a little bit on the picture that we have. First, we are challenged by the fact that we are an archipelago. There are many islands, some of them being more densely populated than others, and some of them having more resources than the others. So you can imagine that transport of supplies can be an issue, and the availability of the cold chain requirements might also be a challenge. We are also doubly burdened, not just by the logistical issues, but also by the fact that vaccine supply has been quite limited. And because of that, we have had to contend with using many different brands and many different platforms because the supply issue was really quite difficult to predict. And government's focus was really just to get whatever could possibly be made available to our population. So this diagram actually shows the role of both the private and the public sector in trying to get a vaccine distributed to the different parts of the country and deployed to the recipients. We have two strategies being employed depending on the cold chain requirements of each vaccine. And for each of these types, there was heavy involvement with third-party providers for cold chain requirements. And once these vaccines reached with the regions, the different regions of the country, I mentioned earlier that policy is drafted in the central office, deployment and implementation by the local government units. So you see that working here because the supplies are sent to city and provincial health offices and to the rural health units before they are actually deployed to the recipients. We also use a prioritization framework looking at the primary goal of reducing morbidity and mortality for COVID-19. And as has been the experience worldwide, of course, we know that the disease targets seniors as well as those with comorbidities. And so aside from our healthcare workers, these were really designated as our A1, A2, and A3 categories that were prioritized to receive the vaccines. But because of supply constraints and looking at the way the disease managed to spread within the country, distribution of supplies was further refined using additional criteria like burden of disease and the capacity of the local government unit as well as the supply chain to be able to receive and deploy the vaccines. Now, if in case a further refinement was needed, then criteria such as exposure and mortality risk were applied for subcategories of these groups so that a rational distribution system could be put in place. So this is what the category A group looks like in our country. A1 is composed of our frontline healthcare workers. Then A2 are our senior citizens aged 60 years old and above. A3 category is composed of our individuals with comorbidities, while A4 is composed of frontline personnel in essential sectors. The indigent population was given a special category, and this was really based on the fact that they might have limited access to healthcare and probably live in very densely populated areas and thus are at higher risk for contracting disease. So far, about 50 million doses of the vaccine have been deployed. And if you will remember, I mentioned earlier that our population is about 110 million, with about 60 million being designated as the target population to receive the vaccine. So with the 50 million doses so far available or deployed, about half have completed their 2 doses, while the remaining half had received just their first dose. Most of the A1 target has already been completed. The vaccination rate for our healthcare workers is about 97% already, and this has been seen to be quite encouraging. But our other targets, our A2 or senior citizens, have really lagged a little bit, such that only in the National Capital Region have we achieved a respectable rate pushing 80%, with the rest of the country averaging about 40 to 50% coverage. A3 is lower by about 10% or so, and we have just started with our other essential health, frontline workers as well as the indigent population. This week has also marked the rollout for our pediatric population, focused particularly on those teenagers with comorbidities and providing primarily Pfizer vaccines because this has been the platform that's available consistently in our country. There has been a lot of concern about adverse events following immunization because of the fairly recent experience in the country of dengue vaccine politicization of dengue vaccine adverse events. And so there was really a significant hurdle with respect to hesitancy, and it became very necessary to assure the public that adverse events monitoring systems would be in place. So aside from reviewing the actual process, there was a lot of communication challenges that had to be hurdled, and a campaign to inform the public that a surveillance system for this adverse events following immunization was going to be available and was going to be actively monitoring individuals post-vaccination. So far, out of the almost 50 million doses deployed, as has been experienced globally, very few adverse events have been reported. And this is about 0.006% of all the doses administered. This table shows us the breakdown of reports attributed to each of the vaccine brands. And you will see that for each of the brands, the reports have mostly been for non-serious adverse events, with only a handful of cases being classified as serious AEFIs. So I'm handing the floor back to Professor Gray for the rest of the discussion.
What remarkable progress both your countries have made. And I want to thank you both Prof. Anna and Prof. Young-Jun, for sharing your country's experience with us. Next, could you perhaps share with us the lessons your country has learned with regard to COVID-19 vaccinations?
Thank you, Professor Gray. There were a couple of points that we could share from where we were in Korea. We did have this issue with the vaccine procurement in the first place. There was a huge political challenge in regard to the limited vaccine supply. But despite that, if you see the slope of the vaccine coverage, it was quite a steep, meaning that once the vaccine had landed on the airport, it was very quickly distributed and the delivery were made. So one of the caveats that we might share would be the online reservation system that shows real-time data on the vaccine doses and the coverage across the nation. And given the internet traffic, there were a couple of the IT companies that helped with the matching the reservation system through their cloud infrastructures. These green lights in the below indicate that traffic is okay. And when the traffic light is red, it means that it's going to take some time. And if you are not the candidate to receive the vaccine on a particular day, you still can get it through the finding the leftover doses. So this is the map that shows the nearby clinics and the vaccine centers that have some leftover doses from the no-show reservation and so forth. So basically, there were 3 channels for the vaccine delivery. The one on the left would be the vaccine centers that were designated initially for the mRNA vaccines, given the availability of the ultra-low freezers that were not really readily available in the local clinics. So if you see the picture, this is basically the mass vaccination campaign in the vaccination centers. And there were more than 10,000 contract sites with the private clinics participating in the vaccine delivery. And so for those who had limited access to the medicine, such as the homeless people, undocumented immigrants, and so forth, there were the ad hoc basis outreach program were conducted in these areas. So to address the public concerns, at first, the transparent operation of the vaccine program was updated at a real-time basis, as the picture shows. And a couple of the famous people, including the president, celebrities, and the chief of the Korea CDC, were at the frontline page in the receiving of the vaccines, like in many other countries have done. Lastly, given the recent roll of the vaccines in the childhood population, there were the voices that needed to be taken into account, meaning that we needed to learn the perception and the acceptability of the vaccines of the children and their parents. So I have had a chance to lead a survey including randomly selected 270,000 students, 270,000 students, and 340,000 parents to learn their acceptability of the vaccines, and found that 79% of the parents and 62% of the students failed to get vaccinated because it would prevent the infection of the individuals. But 90 to 95% of them had concerns regarding the safety issues. And more so, in the setting of having a hard science data in regard to vaccine immunogenicity, efficacy, and the safety in the controlled randomized trials, the decision still had to be made based on the soft science data from the risk perception and the real world safety data. So I had a chance to conduct a Delphi survey on 45 national experts in the vaccines to ask how they would make the sound decision on vaccinating the children for the sake of their best interest. So the average number here means 1 with the least agreement and 5 being the most agreeable argument. And we had some little more than the neutral opinion on recommending COVID vaccination in Korean children among the national vaccine experts. So this was quite reflected in our vaccination policy, and we did not mandate for the childhood vaccination for the COVID at this moment. And so for the takeaway, as a baseline, South Korea has been at a increased risk of the COVID-19 pandemic, and the recent experience of the emerging infectious disease introduction, such as MERS-CoV, we had experienced, and but still we had this robust public health response in the vaccination program. We did have the weakness in the unstable procurement in the earlier phase. We had quite a delayed phase of the vaccine rollout, but through the vaccine prioritization and the planning, this kind of worked out quite well. Through the phased distribution and the channeling through the vaccine centers, the clinics and the outreach programs. And this was also helped by the utilizing the IT infrastructures to run the electronic reservation and searching for the leftover vaccines. There are new concerns regarding to the safety in the childhood vaccination, and we are on the version of the researches, and we are aiming to address for the evidence-based policies to address such issues. And we are continuing to monitor how the general public would feel about the vaccine, how they would accept the vaccines. So here were some couple of the lessons that we have learned from Korea that we could share. So I'd like to pass this to Professor Anna. What would be some of the lessons that were learned from the Philippines?
So thank you, Professor Yongjun. I think in the Philippines, we share a lot of similar experiences that have also been going on in Korea. And I'd like to start off by sharing this diagram coming from the World Health Organization, encouraging countries to work on a national deployment and vaccination plan and consider different aspects that could make vaccine rollout successful for these individual countries. So considerations like regulatory preparedness, costing and funding, making sure that populations are targeted with appropriate vaccination strategies, looking at the supply chain, making sure that acceptance is in place and that safety monitoring systems are also set up, are different aspects that needed to be reviewed in our country, despite the fact that these should already be part of the regular setup, because we do have ongoing vaccination programs targeting childhood vaccines in an NIP. However, we have seen that the COVID-19 vaccine rollout is an unprecedented challenge. Um, the development of this vaccine has occurred at 4 times the previous global record, which is the development and rollout of the mumps vaccine. And the scale at which this is happening is said to be about 4 times the largest programs that we've ever had globally. So, looking at this framework that McKinsey Consulting has come up with, I think is a good way to illustrate what's been happening in the Philippines. So, first, we had to make sure that vaccines were available. I mentioned that our country was really quite challenged because supplies were already committed to a lot of the developed countries. We were working with the COVAX system of the World Health Organization, hoping to receive the 20% that was promised, and trying to utilize internal resources as well as ADB funded um, um, resources to be able to secure vaccines that would still be available and committed by the different manufacturers. So the workaround here was just to try to secure whatever volumes were available and to have them delivered on a staggered basis and to try to deploy to the different regions of the country as the vaccines became available. Next, I'd like to focus on the issue of accessibility. Again, our country is an archipelago. There are varying resources available with respect to cold chain, and most of our ultra low freezers had to be deployed to urban centers, which could assure constant electrical supply to power these ultra low freezers. So that also meant that we could not deploy every type of vaccine or every vaccine platform to every part of the country. And this, of course, was also met with a lot of concern and also some issues regarding acceptability. So next, let me go to issues of acceptance and administrability. So here, this talks about making sure that appropriate individuals can receive vaccination at convenient locations. But before that even happened, we had a significant challenge, making sure that people had accurate information, that they could actually be encouraged to be vaccinated. And this required a lot of public communication to be able to share the correct information. In a setting or in a country where social media is so active and misinformation typically had a chance to reach the consumer much earlier than official communications from healthcare facilities and the Department of Health. So acceptability was an uphill climb. And so that impacted on making sure that enough people would be available at the start of the rollout, at least, to receive the vaccines. And then finally, of course, there's the issue of accountability, making also sure that people could come back for their second dose to the correct vaccination site and could be monitored for any post-vaccination events. So this framework actually illustrates the many issues that the country encountered in the course of the rollout, But perhaps let me end on a hopeful note by saying that we have really seen the impact of vaccination, particularly in this current surge. Among the different regions of the country, it is the National Capital Region which was supplied with the most vaccines, being the epicenter of the pandemic, as well as the economic center of the country's activity. And so, as the National Capital Region reached a coverage beyond 70%, we felt that this was really quite instrumental in ensuring that infection rates could be manageable, and more importantly, death rates could be addressed appropriately. So, as the National Capital Region and several areas of the country were placed under community quarantine, vaccination activities continued, and we feel that this has contributed significantly to the control of cases that we're now seeing, and which has enabled a little bit more loosening up in terms of mobility. So with that, I'd like to end my part of the discussion and hand the time back to Professor Gray.
Thank you very much. This was such insightful learning about your experiences in both Korea and the Philippines. I think this is the end of the panel discussion, but we're going to have a short question and answer session, and we were happy to address any questions from the participants. Thank you very much for attending this session today.